try even to catch up a little bit of time. We have as the next speaker Dr. Sperling from Mönchengladbach, who will talk to us on secondary erectile dysfunction, prevention and treatment. Please.
Mr. Chairman, dear Franz, dear Maggi, thank you again for being here and for your friendship and hospitality. And the weather is fantastic. How did you arrange that? The next 20 minutes, I will try to confuse you a bit about secondary erectile dysfunction and the prevention and the therapy options we have. And I focus on the radical prostatectomy, but you should be aware that there is secondary erectile dysfunction after radiotherapy too, but it just occurs 2 to 3 years later because the vascular damage needs some time before erectile dysfunction can win against the corpus cavernosum. So the structure of this talk will be how are the positive factors for potency after radical prostatectomy. And let's start with the surgeon. The first thing that we should be aware of news in that part. And yesterday you heard from Professor Huland about the nerve distribution. This is a major thing. Another story is that there might be accessory pudendal arteries, and you don't have to find it, but you just have to be aware about that, because I think our patients observe it, that we are on the top knowledge in our part. Because surgical impact is always in the discussion about the volume of the surgeon is performing on radical prostatectomies or even other operations. And in Germany we have the so-called prostate cancer centers from the German Oncological Society, and there you need 100 radical prostatectomies in your life, and you should perform 25 radical prostatectomies per year to be a certified surgeon. I know for those here in this room, this is less. But if you look in the literature, okay, this paper is from 2002, you can see that you're a very high surgeon or a very high volume surgeon if you do more than 33 radical prostatectomies. That's not so much. I'm sure you deny that. On the other hand, we have different techniques, and if we compare the outcome of these techniques, surgical techniques, you have always to be aware how the comparison was made. Here you can see wonderful results on potency rates for robot-assisted radical prostatectomies in comparison to the open procedures. But in Germany, we say you compare apples with pears. I would say this is like tomatoes and cucumbers, because the nerve sparing in the robot-assisted radical prostatectomy group was a non-nerve sparing was performed in 30%. In the open radical prostatectomy group, it was performed in nearly 50%. How can you compare these groups? And the second thing on that is, it's the same with the pathological stage and with the positive surgical margins. So this is not fair to compare groups with that differences, and even then do the marketing afterwards. You should do it in that way. Maybe you should do it in the best way you can. The second, I think, very important thing is, what about the neurovascular bundles? How can we prevent, how can we preserve them? You know about different techniques again, and we know that the intrafacial dissection here in a robotic assisted operation, a photo of that maneuver, you can see that the potency rates range up to 90 or even near to 100%. I'm always a bit of fear if I see potency rates which are better afterwards than before. But the best thing on this study is that you can see over the time, over the months 3 to 6 to 12, there is a climbing up of the potency rates, so that you can see time cures too. And this is an important thing for our patients if we I'm losing a word. If we are talking with them. So Then there are sophisticated things like intraoperative monitoring. We heard about that. This is an older paper from the last century, but it's still work to work on those things. How can we preserve more nerves, more neurovascular bundle? But there are things that are left, like the psoriasis interposition. I think no one is doing that anymore. And even if it started very encouraging, but now it's lost. And always if we see the results on this encouraging or more or less good procedures, we have to ask ourselves, where is the cutoff? Where is the reliable cutoff for erectile recovery, bilateral or unilateral nerve sparing after each operation, which can harm erectile function? Is it 17? An IAF of 17, it doesn't reach, or it isn't enough for a sexual intercourse or for a sufficient or satisfactory intercourse. So the IAF should be more than at least 22 in the 5-question IAF. Briganti wrote that last year, and I think this is very important because then the erection is stiff, then it is hard enough for a satisfactory intercourse. Third thing, good erectile function. We all know that the erectile function is losing over the years, even if the papers, if the press will give us the impression that there is no age, no end of aging. But as you can see in results from the leading Rehabilitation Center for Urological Diseases in Germany, this is data from Professor Otto from Bad Wildungen, you can see that the erectile status before vertical prostatectomy, it is getting worse with the age. That is nothing new for us. And if you compare that, and that's a lot of water in the wine, with that erectile status after radical prostatectomy, this is data right from the Rehabilitation Center, more than 5,000 men, and all of the German urologists in this room know Professor Otto, and a lot of us refer their patients after radical prostatectomy to this center. Then you can see that the E4 to 5, this is hard enough for satisfactory intercourse, the erection 4 to 5, then you can see that there is an erectile status of almost 2%. That's not fair. Right after the operation, within the first 6 weeks. More for that what is with the age. Here again, potency rates after laparoscopic radical prostatectomies. The group 1 is less than 50 years, group 2 is 50 to 60, and group 6 is more than 60 years. And they can see that with the nerve sparing, then you can achieve potency rates of 70% in the youngest group and less than 50% in group 3 with more than 50 or more than 60 years, even after nerve sparing. The same in Florida. Here you can see the same results. Potency rates are declining with the age of the patient, so we can state that this is nothing new. This is new. This is a paper from France. The first part is not new. If you're younger, you have better erections than an older man with 70 years or older, almost a predicted postoperative potency rates of 33%. But the second part, it's whether polite nor it's charming. It's the partner's age. It's how old are the women and how big is the difference between the patient and the partner. If it's less than 1 year, then your predictive potency rate is 25%, and if it's more than 20 years, then the predictive potency rate is 90%. So even the partner has some influence. What is with the time after radical prostatectomy? This paper is very nice because there are 3 German and Austrian surgeons headed against each other with a retroperitoneal approach, a perineal approach, and a laparoscopic approach. And the most important information is this here. After 2 years, more or less, the same potency rates are the result of the 3 different techniques. So the battle of techniques was stopped, but the time is a very important part of curing potency after operative treatments. And then you can see that we have different surveys how we can do penile rehabilitation. And this is a survey of the last year where AOA members were asked, and 618 responded the question of the AOA team, how they do penile rehabilitation after radical prostatectomy. And this is compared to an older arbeit of the International Society of Sexual Medicine and a survey on the French urologist. And how is it in the US? You can see that private praxis, 437 out of 618, so 70%, and academic centers in almost 30%. And the first question was, what do you do afterwards? Which strategy do you put at the first choice and which as the second choice? And the overwhelming answer was PDE5 inhibitors as the first therapeutic option. The second one is the vascular erection device, vacuum erection device, and the third option is the intracavernosus injection. I think transurethral prostaglandin E1 application is almost gone. It's only for a few of the patients. The second question is when? Almost 10% used nothing of sildenafil, vardenafil, or tadalafil. And of these PDE5 inhibitors with the different acting times, 10% were on demand. The majority of the PDE5 inhibitor users took it at least 1 to 2 times per week or 3 times per week, and only a few or only a third took it daily or nightly. So you can see it is a very heterogeneous answer. It's the same with the preferred timing to start rehabilitation immediately. So that means in the hospital, 11%. This depends on the old quote, do it or lose it. So train it or lose it. And the other, and the vast majority said after catheter removal. I think that is what the majority of us would suggest, because it's not nice to have erections with the catheter if they appear. And the duration of rehabilitation, it's more or less the same. It's between 12 and 18 months. Only a few do it less than 12 months. Maybe these are the successful men where the penile rehabilitation wasn't necessary because erectile function could be preserved. How is it in Germany? Here is a paper, Banowski former at the Kiel University by Klaus-Peter Jünemann. They can see that they were doing a nightly dosing with a small amount of sildenafil, 25 milligrams, daily, nightly, and they suggested that there was a significant improvement over the time with PDE5 inhibitors. But if you remember the IAF of 22 as a reliable cutoff, then you can see that this cutoff is 15. And if you are honest, what shall we do with an IAF of 15? Then we waited in the same year for the results of the Reinvent study. Francesco Montorsi was the principal investigator, and his aim or the goal of the Reinvent study was to demonstrate for the first time the hypothesis of pharmacological prophylaxis, that we can do a good job for our patients if we address them that they should use a PDE5 inhibitor, in this case it was vardenafil, nightly as a daily dosing. And the charm of this study was that it was compared to vardenafil on demand and placebo over a phase of 9 months double-blind, and then it was unblinded and was one side blinded with placebo or vardenafil on demand. Everyone suggested that there might be the best results we should ever get. We got the honest results we ever saw. Because in this study, we could see that even on demand or on nightly or daily dosing, the SEP3, the sexual encounter profile 3, was your erection hard enough for a satisfactory intercourse, or did it last long enough for a successful intercourse, was reached by almost a third of the patients, and later on overphased by 45% in the on-demand group. That means best selected patients, operated by the best surgeons, and the potency rates were definitely lesser than we saw it in the papers before. At the end, 2 remarks. Are there other things that harm sexual activity after radical prostatectomy? Yes, there are. The first thing is urinary incontinence. In this slide, you can see that there are different forms of sexual activity compared with daytime incontinence, orgasm-associated urinary incontinence, or no orgasm-associated urinary incontinence. And this harms sexual activity of this man and in these partnerships. You can see the ratios for not being able to satisfy the partner were higher in the group with incontinence. Those patients avoided sexual activities because they had fear of failing, or they had fear of getting orgasm or not orgasm-associated urinary incontinence during sexual intercourse. So this is a major important fact. We need continence if we talk about sexual rehabilitation. And then there is an impact on the female sexual function index. This is from Mrs. Herkommer, now in Munich, and she asked 104 partners out of more than 1,000 male patients after radical prostatectomy, or she got answered the questions by 104 female partners. And they asked them with the female sexual function index. And due to the postoperative erectile function status, whether they were potent or they were potent with the PDE5 inhibitor, there was no chance between the pre- and the postoperative female sexual function index. That means the female sexual integrity index for sexuality of these men pre versus postoperative. And if you use an intracavernosus injection therapy or the vascular erection, the vacuum erection device, then you have significantly lower female sexual function index scores, so that means that sexuality is lower. At this point, I have to add one very interesting thing. The female sexual function index doesn't change if you use an inflatable penile prosthesis, because then the partnership is so stable that they decide together for this. So in conclusion, suggesting that we are the ideal doctors for our patients, we need to prevent erectile function. The ideal patient, he should be young, he should be potent, and we all know that this is not the regular patient we see in our offices. We have the freedom of a patient-dependent therapy, and we can decide what and when, and maybe it is part of the type of the insurance system. In Germany, we have the situation that the PDE5 inhibitors aren't paid by the insurances, and so a lot of patients take the vacuum erection device system because this is paid. And if you look on this FSFIE index scores, then you know that that is a pity. So at the end, if we have this ideal doctors, ideal patients, and the patient's dependent therapy freedom, I think we can avoid that the patients come to us and say, I've lost my manhood. Thank you very much.
For sake of time, we have time for just one question.
What do you think about the concept of giving PDE5 inhibitor before the operation, as shown in animal studies from the UCLA, to protect erectile function postoperatively?
As you saw, that there is no difference between on-demand and even if you wait And if you start later, when the operative trauma has gone, I would suggest patients to do that. If they are very eager with that function, if they say, the main goal for me is not to lose my potency, and if they can pay it, then they should do it. It's free.
Sure.
I wondered if you had some thoughts on the use of the vacuum erection device after surgery. How frequently, and is it beneficial?
It's very good, the vacuum erection device. You see success rates of 70 to 80% if you're looking in the literature, but a lot of the female partners don't like it because the penis is getting colder, sometimes it's blue, and so it's not very charming. I'm a urological andrologist, so excuse me.
So, but use just to maintain penile compliance rather than for sexual activity, just to use it for purposes of...
Like penile, to avoid penile shortening, then you can use it, yes.
Yeah.
If you want to use it for that, then it's a good thing. But if you want to use it for sexual intercourse, I would put it on the first hand.
Okay, well, thank you very much.